Sometimes what can happen is that as we are resting, of course even the tumor cells are growing. As our normal cells are trying to grow and recuperate, so are tumor cells. And some of those tumor cells actually become very clever and escape from this cycle. And when they escape from this cycle, now they are becoming stronger. That chemotherapy is no longer affecting them, and that is what we call resistance. So this clone of tumor cells starts now growing and becoming resistant. So we have patients who you give chemotherapy, it works beautifully, it works wonderfully, and then after some cycles you find that, oh my God, this chemotherapy is not working, what is happening? And the doctor gets stressed, the patient gets stressed. So this is what has happened. So we have gotten into a resistance, and we need to at this juncture change the kind of treatment we are giving or the drugs that we are giving, so that we can give something else. That usually happens when there is a metastatic cancer rather than when we are treating early cancer. So when we are giving treatment in cancer, what are our goals? One is that if this is an early cancer and you can eradicate cancer, or this is very chemosensitive cancer, we want to get rid of that cancer. We want to make that person free of cancer. Goal number one. Goal number two is that if eradication is not possible, this cancer has already spread, the seedlings are all over the place, you cannot remove it by surgery, it's bound to grow at one point or another, then we can give chemotherapy with a palliative intent. Palliative intent does not mean that you are just going to die and that's your fate. Chemotherapy given with palliative intent can have overall survival benefit. We have many patients who are stage 4 cancers and they are receiving chemotherapy and cancer treatments, and they are surviving years and years down the line. We have had some of the patients who are more than 5 years surviving because of palliative treatment. Now what we really need to remember, and this is one of the big take-home messages that I want all of us to go with, is that cancer treatment is not a one-man show. It's a multimodal and a multidisciplinary treatment. So multimodal means what? You're not only going to use chemotherapy in the treatment. You need to use chemotherapy. There are other modalities. You can use radiotherapy. You can use surgery for it. That's why Abdi is here. Radiation oncologist is needed. And it's a multidisciplinary. Sometimes we just take the oncologist, we take the oncological surgeon, and we take the radio-oncologist, and we say we've done a good job. No, my dear colleagues, we've not really done a good job. We need to involve the other cadres as well, because we need to ensure that the social workers are coming in, we need to ensure that the nutritionists are coming in, we need to ensure the psychologists are coming in, we need to ensure the imams are coming in, and the other religious leaders are coming in, because there are so many aspects that we need to take care of. The second thing that I need you to remember is that the first line of treatment that we usually give for cancer, that's the best chance of cure, or the best chance of decreasing cancer that we are giving. The most effective kind of treatment is usually given as the first line of treatment. All right. Some of the things that we need to do before we start treating cancer. We need to have an accurate diagnosis and an accurate staging. Sometimes many doctors get frustrated just at this first stage of trying to get an accurate diagnosis. Please do not treat a cancer before you have a histological diagnosis. You need to see what kind of a cell it is, what kind of a growth it's going to have, from what kind of a grade it is, and the stage. I have had many patients, unfortunately, who you see on a radiology that yes, the prostate gland doesn't look very nice. Some of them might actually have mets as well. The PSA is high. Is that prostate cancer? Yes or no? Yes, most likely so. But it is important for us to get the histological diagnosis, because prostate cancer, we need to know what is the Gleason score of the prostate cancer so that we can know how aggressive this cancer is going to be. We need to know what is the histological type of that prostate cancer. Prostate cancer can be adenocarcinoma, prostate cancer can be small cell carcinoma, prostate cancer can be a sarcoma, and the treatment modalities are different for each of them. Staging is also important. Just let's take an example of a breast cancer. The way you are going to treat stage 1 breast cancer is very different from a stage 2 breast cancer. Stage 1 breast cancer might not need adjuvant chemotherapy. Stage 2 breast cancer, depending on what the histology looks like, may or may not need adjuvant chemotherapy. Stage 3 cancer might need neoadjuvant chemotherapy before you do the surgery. Stage 4 breast cancer, your whole intent is different because it is palliative in nature. So it plays a huge role in what we are going to do, how we are going to treat, what modalities we are going to use, and what our intent is going to be. So chemotherapy basically means that we are using drugs to kill cancer, and those drugs could be many different type of drugs. They could be cytotoxic drugs, they could be hormonal drugs, they are biological agents, and now we have targeted treatments and biologic agents or signal transducers. These are all different classes of chemotherapeutic drugs. Now this animal hops in again into the lives of oncologists to distress them, because each of those drugs is going to act at a different step of the cell cycle, and each of those drugs is going to act in a different manner and stop a different kind of a growth. So why is that important? Because generally we would like to have more than a monotherapy. Monotherapy could result into incomplete responses. So we would have multi-agent chemotherapy. And when we are choosing those multi-agents, then we want to choose them from the drugs which are acting at a different place in the cell cycle. So once we have given treatment, how do we measure the response? We could have a complete disappearance of tumor, which we call that complete response. Or we could have a partial response. That means that the tumor is decreasing by more than 50%, but it's not clearing at all. That's a kind of a response, and it is accepted in especially in metastatic setup. Or we could have a stable disease. A stable disease means that there is less than 25% of response, but there is no growth of that tumor, and that's also a response accepted in metastatic setup. Or we could have a progressive disease. It means that the disease is now increasing, and that's the time you need to change your treatment. Now we looked at resistance. So resistance could either be intrinsic or extrinsic. Intrinsic means that the genetic makeup of the cell is such that it's just going to be resistant to that particular drug. Extrinsic could be because of the way we are delivering that chemotherapy drug, or because of the way the tumor is. It might be very poorly vascularized. It might be there might be hypoxia there, or we are actually underdosing. And sometimes we cannot help but to underdose, because the patient is not really tolerating the chemotherapy very well, so we might start at 75% of the dose or 80% of the dose, or we might give suboptimal treatment. For example, like now you have a lymphoma, it's an elderly person, so you might choose 2 drugs instead of the 4 or 5 common drugs or something like that. Okay, so when we want to treat, we want to start while the tumor load is as low as possible for a better outcome. We want to change to an alternative treatment as soon as possible if the drugs are not working. And once we have found that we have cleared, we want to give 2 or more cycles to clear the microscopic cells. And if possible, we want to use a combination therapy. These drugs are heavily toxic. Please do not forget to look after your toxicities, especially myelosuppression, neutropenias, anemias, thrombocytopenias. Take care of the GI symptoms, the nausea, vomiting, diarrhea. Alopecia is common in most of the drugs, but generally, once counseled well, it's accepted. In younger patients, we need to take care of the gonadal dysfunction. We need to counsel them that the males might not be able to father children, and women might also not get children after that. Skin, oral ulcers are also important. And generally, what is very important is supportive care, which means that we need to look at treatment of infections and prevention if they become neutropenic. We need to look at nausea and vomiting, ensure we are giving adequate pain control, nutritional support, blood component, and many of us forget about the psychological support. So I think time does not allow me to go into palliative care, but we will stop here. Thank you.
Thank you very much, Dr. Riaz, for the timeless PAL speech. Multimodality and multidisciplinary is always key to a better patient outcome. Thank you very much. Now it's an opportunity for the doctors behind curtains, pathologists. These are the doctors. They are the pillar in the management of our patients. So with that, I will let Dr. Abdul Aziz to welcome the pathologist.
Thank you so much, Dr. Abdurrahman. So I don't know, Dr. Bajabir, if you can give an update on the question and answer module